Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We are so happy that you chose to spend some time with us today, and we think that you will find the subject that we are discussing timely and needed. Without further ado, I will turn it over to our founder, Dr. Randall Maxey.
Good afternoon, Dr. Neighbor Stevens, Dr. Ivanwalks, Dr. Hines, and Ms. Romero, and especially our speaker for today, Dr. Dal Hewlett, who's one of my friends from back at Old Harlem Hospital years ago, who's a distinguished gentleman. Dr. Neighbor Stevens is going to introduce him in just a moment. But I want to start out today honoring a fellow physician, warrior, uh, who happened to pass this week. Today, I want to remember and honor the extraordinary life and legacy of Dr. Alvin Toussaint, a distinguished physician, psychiatrist, writer, and professor. Dr. Toussaint was a trailblazer in the fields of medicine and social justice, using his voice to advocate for equity in healthcare and beyond. His work profoundly shaped our understanding of race, culture, and mental health, leaving an indelible impact on generations of physicians, scholars, and activists. His wisdom, compassion, and dedication to justice will be greatly missed, and his influence will continue to inspire. We extend our deepest condolences to his family, friends, and all those who were touched by his remarkable uh, career. And we give honor to him, and we sorely miss him. Thank you so much. We'd like to move forward with our program today with Dr. Neighbor Stevens introducing our speaker for today, Dr. Dal Hewlett.
It is my pleasure to present to the audience today, not really an introduction because Dr. Hewlett has been with us before. Dr. Hewlett is currently the medical director at the Division of Disease Control and chief of tuberculosis services in Westchester County, New York. He also has academic ties with New York Medical College, as well as Calvary Hospital in Bronx. Now, Dr. Hewlett, I invited Dr. Hewlett to come today because he is an infectious disease specialist. And although we got started because of an infectious disease, we have branched off into many other areas of medicine since that problem cooled down some. But now we got some new problems that we need to deal with. And this is a time where information is most important and not various versions of the story. And he is eminently qualified to keep us on the straight and narrow when it comes to what the significance of the different flus, as I like to call them, that are affecting us now, as well as a couple of other highly infectious uh, diseases that are currently kind of raging in the country. So without further ado, I'll turn it over to Dr. Dial Hewlett.
Thank you very much, Dr. Navra Stevens, and good afternoon to all of you. It's an honor to be here, and I certainly have enjoyed over the years being connected and reconnected with Dr. Maxey. I always tell the story about how when I was a medical student, I was actually shadowing Dr. Maxey in the emergency room at Harlem Hospital, and I decided as a medical student that that was where I wanted to do my training. And so we go back many years. So today I'm going to talk about influenza. We're going to spend most of the time talking about the highly pathogenic avian influenza, as it's called, or bird flu. And I then am going to go into a little bit about the standard influenza A. And then I will spend the remainder of the time updating you and updating all of us on where we are with the measles. So I'm going to try to share my screen now, if I can. See if I can find my presentation. slideshow. Okay, so here we go. So here's the outline for our discussion today. I'm going to start with providing you with a status report on influenza H5N1, now known as highly pathogenic avian influenza. We'll say a little bit about the epidemiology. We'll talk about the cases that have been occurring in animals, cases in humans. We'll talk about some of the rather disconcerting things that have occurred over the last few weeks, having to do with mutations in the virus and what the implications of those mutations actually are. I don't have any slides to talk about the preparations for dealing with this, but I am very, very concerned that we as a nation are not prepared for dealing with this virus, which has the potential to become a pandemic. We are hoping that it does not, but it certainly has the potential. I'll say a little bit about influenza A and B in the US, which is still a major problem. And in our African American community, it remains a major problem because we cannot really convince everyone that they should be vaccinated. And the take-home point from influenza is that everyone 6 months of age and older should be getting vaccinated. The vaccinations are effective in preventing hospitalizations and death. And I always tell our patients that we can't expect to prevent every single case of influenza with the vaccine. But certainly if someone gets a mild case, I always tell them that chances are, since you had the vaccination, it wasn't as severe as it would have been. We'll then close by updating everyone on the measles. I'll say a couple of things about the historical perspective, the fact that we actually had measles eradicated back in 2000, and now it's a problem again. We'll say a little bit about the outbreaks that are currently occurring here in the United States, the large outbreak that started in Western Texas. And then we'll talk a little bit about vaccination status and the risk for future outbreaks. So we'll start by talking about the highly pathogenic avian influenza, or HPAI, as it's now called. And this is a rather disturbing picture showing dead birds that had to be culled. And anytime you have a infection that occurs in a flock of birds on a farm, whether it's chickens or other types of poultry, you're obligated to essentially cull the entire flock. One of the things that happens in the birds is that if they become infected, they will usually die within a period of 2 or 3 days. Now, this highly pathogenic virus, and let's see if I can adjust this, highly pathogenic avian influenza, H5 bird flu, is widespread in wild birds worldwide, and it is now causing outbreaks in poultry, and also it has crossed over to dairy cows, and some recent human cases have been reported, and we'll go through those. And there was a recent article in the New England Journal in December, which described the experience with bird flu in individuals. Primarily, the people that are involved primarily are people that work in the dairy industry and people that work in the poultry industry, but there have been other cases that have occurred in individuals who are outside of those groups. So while the current public health risk is considered low, the CDC is watching the situation carefully and working with states to monitor people with animal exposures. Now, how is H5N1 bird flu spreading? It's believed that it is spreading from the poultry, and the wild birds are essentially giving it to the poultry, and the poultry, the chickens for the most part, are transmitting it to cows and to dairy cattle, and transmitting it also to humans. The cows that are on the same farm, of course, are getting it in that way. And then most recently, there have been reports of the bird flu in domestic cats. And that's been somewhat troubling because you are now seeing changes in the virus that seem to be occurring as it is transmitted from one mammal to another. So far, there has not been documentation of human-to-human spread. But one of the things which we have to keep in our minds is that we're only a few mutations away from that. And the people at the Johns Hopkins School of Public Health have been watching this very, very closely, and they have made us aware of the fact that some of the mutations that are occurring are in the vicinity of where there is control over the pathogenicity of the virus and the ability then for the virus to spread. Now, this problem has affected just about every part of the United States. This is data from the National Wildlife Health Center in Wisconsin, and this is data from just the month of February. And the dark spots you can see are areas where it has been confirmed in wild birds in those particular counties. And there aren't too many places in the United States, as you can see, that have been left out. There's a dense involvement in the state of California, and certainly in some of the Western and Midwestern states, and also in the state of New York and some of the Middle Atlantic states. Now, person-to-person spread so far, fortunately, has not been documented to date. Again, the current public health risk is considered to be low, but that could change in a matter of a very short period of time if mutations start occurring. Now, to date, there have been about 70 human cases that have been documented. The total number of cases in the state of California is about 38. Deaths in the United States, to date, there has been a single death. There was also a death that occurred in a person from Canada, and that person was from British Columbia. And we'll say a little bit more about that. As far as the exposures, what were the sources of infection believed to play a role in these individuals? Well, one of the things that we know is that most of it has come from dairy herds, cattle. And you can see that 36 of these cases were from dairy cattle. And this is in the California cases, I'm sorry. None were actually from poultry, and 2 exposures were from sources unknown. I picked out California because of Dr. Maxey's connection there. And one of the things that I didn't realize was that California is probably one of the leading states for dairy production. Now, in terms of detection in animals in the U.S., as of February the 25th, there were over 12,000 cases where wild birds were detected to have this virus. And so we know that it's definitely more widespread than that. That's the number of birds that were actually tested. 51 jurisdictions with bird flu in wild birds have been documented to date. 166,000, over 166,000 poultry affected. And of course, this has led to the culling of the flocks, and this has caused problems with our economic situation that we'll talk about. And there are 51 jurisdictions with outbreaks in poultry. 976 dairy herds were affected as of the 27th of last month, and 17 states with outbreaks in dairy cows. What are the signs and symptoms of H5N1 infection or bird flu? They're very similar to what we expect to see in the normal influenza. However, conjunctivitis seems to be one of the factors that is very, I guess, significant in patients with bird flu. But the highly pathogenic avian influenza virus have caused widespread infection in the dairy cows, and this actually got out of sequence. I think we went out over this already. But in terms of the actual patients, the median age of patients across the country has been 34 years. And we've mentioned already in terms of we had one case in which there was no identifiable source. Now, in terms of the symptoms and signs, of 42 patients that were actually evaluated, 93% had conjunctivitis. And this is from the article from Dr. Garg and colleagues in the New England Journal of Medicine in December of last year. They reported the results of 42 patients. 93% had conjunctivitis, 49% or 22 had fever. 36% had respiratory symptoms, and 33% had conjunctivitis only, which is very interesting. These patients actually just presented with conjunctivitis, and you would think that this would be, say, a case of pink eye. But when they actually did the swabs and sent off the swabs for testing, it was actually H5N1. Um, the median duration of illness among 16 patients with available data was 4 days. The range was from 1 to 8 days. Most of the patients, about 87%, received oseltamivir, and oseltamivir was started at a median of 2 days after symptom onset. We usually recommend and we usually encourage the initiation of oseltamivir or Tamiflu as soon as possible. It's ideal if it can be given within 48 hours. However, for bird flu, they have actually written out, the CDC has actually drafted emergency guidelines where physicians and practitioners are encouraged to stretch it out and to offer it even longer, even beyond the usual 48 to 72 hours, because you may have very serious symptoms in some individuals. And so for that reason, that the new guidance has actually recommended administering it, even if the patient presents, 5 or 6 days into the illness. To date, there have been no additional cases identified among 97 household contacts of the cases. And so based upon this initial experience, they believe, and we believe, that person-to-person contact is not occurring, because we know that if this was normal influenza and if you had household contacts, it is very likely that those household contacts would have become ill. So in the cases of H5N1, fortunately, the illness has usually been mild with the conjunctivitis of short duration, and the predominant exposure in the infected in adults has been infected animals. Most of the people have been people who have worked in the poultry industry or in the dairy industry. And as we said already, no evidence for human-to-human transmission. And the authors of the New England Journal article mentioned that the use of personal protective equipment was suboptimal in many of the individuals who were infected. And as a result, there has been new guidance for people that are working in the poultry industry and in the dairy industry as a result of this outbreak. And we've mentioned already that most of the time the severity of illness is mild. However, there have been cases of severe illness, and there has been, as we mentioned, one death that occurred in an individual, and that was in the state of Louisiana. And also, there was the death of the individual in British Columbia, Canada. And if we have mild illness, these are some of the things that you are likely to see, which would be typically seen with the flu. Sometimes you have fever, the eye redness or conjunctivitis is really a cardinal manifestation, sore throat, runny or stuffy nose, muscle and body aches, headaches, and fatigue. The time when a person is exposed and infected with avian influenza viruses to when respiratory symptoms begin is about 3 days, but it can range from 2 to 7 days. And as we mentioned, and we keep saying this over and over again, the eye symptoms such as redness and irritation can occur 1 to 2 days after exposure. And it was believed in some of the early cases, and there were discussions in the health departments about this, that possibly on the dairy farms there might have been aerosolization of the milk from infected cows, and that might have been the way in which some of the patients actually got the infection. And if there was aerosolization, it may have been the aerosol may have then flown into the eyes of some of these individuals. And of course, something similar might happen with the poultry. This is a photograph of a young person who was diagnosed with H5N1 and had the conjunctivitis. And you can see here, it's rather nondescript, kind of a same type of thing that you would expect to see with pink eye. Now, what about the contagiousness? The period of contagiousness for a person with mild illness due to bird flu is not well understood yet. We believe it's probably similar to seasonal flu. People are thought to be most contagious during the first few days of their illness. People with severe disease, for example, pneumonia, those requiring hospitalization, may have high levels of the virus in the lower respiratory tract, and they may actually be contagious for several weeks. And so this has implications for us, for those of us who work in hospitals, and we're asked to make recommendations with regard to isolation. This is something that is quite relevant. And the disease can cause symptoms in individuals for several weeks. As far as recommendations for influenza antiviral treatment and chemoprophylaxis, outpatients meeting epidemiologic exposure criteria who develop signs and symptoms compatible with influenza should be referred for prompt medical evaluation testing, empiric initiation of antiviral therapy with oseltamivir, which is given twice daily for 5 days as soon as possible. We would urge you to utilize the resources, if it's possible, of your health departments, your local health department or your state health department. We certainly get involved in our health department. We're a county health department, and so we're currently involved with an outbreak that has occurred in individuals who worked on a bird farm. So the clinical benefit of the oseltamivir obviously is greatest when it's administered within 48 hours of illness, but we are certainly administering it even out for much longer periods of time, as we said before. Now, what about individuals who are hospitalized? Well, hospitalized patients who are confirmed, probable, or suspected cases of human infection with HPAI, highly pathogenic avian influenza virus, regardless of the time since the onset of illness, are recommended to initiate antiviral therapy with oral or enterically administered oseltamivir as soon as possible. Antiviral therapy should not be delayed while we're waiting to make the diagnosis and to get the results. Now, what about asymptomatic persons with bird or other animal exposures who test positive for H5N1? Asymptomatic persons exposed to animals infected with H5N1 virus who reported not wearing recommended PPE or who experienced a PPE breach in recommended PPE and who tested positive for influenza virus should be offered the oseltamivir therapy. Exposed asymptomatic persons who test positive for influenza should wear a face mask when in close contact with others and should continue to be actively monitored for signs and symptoms of acute respiratory illness or conjunctivitis for a period of 10 days after testing positive for H5N1. Now, what about vaccination? The vaccines are actually under what can I say? A lot of the work that should be going on to develop vaccines has not been going on at the pace that it should be. I think that everyone understands why that's problematic, and I think everyone understands why those of us in the infectious disease area and in public health are extremely alarmed and concerned that we are not able to support the level of research that's needed and the level of support for the vaccine developers that is needed. Just as an aside, and this is not on the slide, you may have read over the last couple of days that a large contract of over $500 million, which had been granted to one of the vaccine manufacturers, was actually discontinued or pulled back by the current administration. And that was just for one particular manufacturer who had been previously involved with the development of our COVID vaccines. And so you have companies that have the technology available, but they had grants from the government, but then the grant support is being discontinued. Seasonal influenza vaccines do not provide protection against human infection with H5N1. So our regular flu vaccines do not work and do not protect the individuals from H5N1. We need a specific vaccination, and there are some candidates that are out there, but they need to be rigorously tested. And that's the part that is being stalled because of the current situation. In terms of if you happen to be in a situation where you are trying to make a diagnosis in a patient, I would highly suggest that you work with your health department, but just for knowledge sake, the preferred clinical specimens, the nasal pharyngeal swab and the combined nasal oral pharyngeal swabs should be tested separately. If the patient has conjunctivitis with or without respiratory symptoms, both a conjunctival swab and a nasal pharyngeal swab and or nasal swab combined with an oral pharyngeal swab should be collected. And if you have a patient who has severe respiratory disease, we also should send lower respiratory tract specimens. If the patient is intubated, endotracheal aspirate or bronchoalveolar lavage specimen should be collected. If you have a person who's not intubated, but if they're able to produce sputum, then a sample of the sputum should be sent. For severely ill patients, multiple respiratory tract specimens from different sites should be obtained to increase the potential for virus detection. So I think that there is not I think, I know that there's an effort to document these cases as well as we can. And the state health department officials should investigate potential cases of H5N1 virus infection as described. And they then have to notify the CDC within 24 hours of identifying a case, and that will be then a case under investigation. Now, what about the economic and societal impact? I don't think I have to tell you about that. I think everyone knows about that. But according to the projections, I think that we can all expect record high egg prices throughout 2025. And so I think that those who enjoy omelets and other types of meals might have to pay quite a bit in order to have those types of breakfast foods. The bird flu has cost the U.S. poultry industry $1.4 billion. And it's estimated that overall across the country, there's been a 5% decrease in egg production. I actually think it's probably much more than that. We've seen soaring egg prices in the New York area. I think there's some places where it's costing $9 and $10 for a dozen eggs. And my daughter was telling me that she actually saw a store where they actually are selling a half dozen eggs at a time now. And it's estimated that there will be a 39% increase in egg prices. That's has been occurring as of January of 2025, and this is data from the Bureau of Labor Statistics. Now, what about the issues with cows? One of the issues with cows that's causing an economic issue is cows that are infected. They will survive, unlike the chickens and the birds. However, in the dairy cows, there will be a decrease in the production of the milk, in the amount of milk and also in the quality of the milk. And the virus is present there. So outbreaks of the H5N1 continue to rise in dairy cattle. And it's important to keep that in mind. And recently there has been a case now that's been confirmed in a pig. The human cases also continue to occur primarily, but not exclusively, in people who have had exposure to the infected animals. And this was data from a few months ago now, so this is old data. But at that time, there were over 600 cow herds that had been confirmed to be positive. And this was a problem as far as the economy, particularly in California, which was considered to be the epicenter for the dairy cow outbreak. And one of the things that has occurred, of course, is that when you isolate the virus from a dairy cow, then that herd is essentially quarantined, if you will. And that, of course, has been an economic problem for the farmers. So although California, which is the leading dairy state and the epicenter, they are starting to get a handle on things there. And there has been a decrease in the new herds. But as we said, there were well over 300 herds nationally. I think it was probably closer to 600 where we are. And one important thing for us to keep in mind, and it's very difficult, I think, sometimes to convince people because of a lot of the enthusiasm around natural foods and organic foods, is that raw, unpasteurized milk is a potential source of H5N1 infection. It has been implicated as possibly being a cause of the disease in cats. And also, we know that this could certainly cause disease in humans if they ingest raw or unpasteurized milk. And so we urge people to not use or to ingest unpasteurized or raw milk. And though there have not been confirmed human cases from raw milk, there are examples of animals becoming infected as a result of the raw milk. So we tell everyone, do not consume raw milk and do not feed raw milk to domestic pets. Now, the bird flu is starting to raise some red flags among health officials. And on January the 6th, and we alluded to this earlier, the Louisiana Department of Health announced that a patient hospitalized for H5N1 avian flu had died. And that person became the first U.S. death from the virus. As far as we could tell, this individual was not immunocompromised, although I don't have all the information on that case. Now, to make matters worse, samples that were taken from this individual suggest that the virus mutated within the patient after infection, meaning that it had begun to adapt to infect humans in a better way, so to speak. And this raises new questions about H5N1's pandemic potential. So I think we're dealing with a serious, very serious situation here. And I don't think that the government agencies are really responding to this as they should. And that's putting it very mildly. H5N1, this is according to the scientists at Johns Hopkins, is a dynamic virus that poses an increasing threat in terms of spillover and the pandemic potential. And when I listen to and read what some of the basic scientists are saying, it's like we're, maybe a couple of amino acids or mutations away from a virus that will be capable of being transmitted from human to human. And if we get to that, we can potentially have some serious problems. And so we know that there have been deaths as a result of this. And the individual who died in Louisiana actually was raising chickens. And some of the chickens and the wild birds that were being raised by this individual were found dead. And this person then became hospitalized and died. And if it wasn't serious enough, when CDC scientists sequenced the samples from this individuals, they found that the virus had mutated at two particular sites that they know are important for H5N1 to adapt to better replication in humans. And one of the problems is that as you go from infection from one mammalian species to another, this adaptation is more likely to occur. And think back to the COVID days. All of this started in non-humans. This started probably from bats or other animals, and then there was a changeover, an adaptation. When we go back to SARS one, we know that started in the so-called civet cat, and that it was then transmitted to humans, possibly through a bat. And this is how the disease can actually be transmitted to cats. We know that cats that go outside, if they see a dead bird, they're likely to consume that dead bird. Or if they have birds that are sick, that aren't moving very well, they're more likely then to become the victim of the cat. And the cats that's become ill and often die very quickly as a result of this infection. So this is a dangerous situation, a very dangerous situation. When the virus infects cats, it causes extremely severe disease, with very high mortality rates. And so we have all of these people who have domestic cats. And there have been product recalls now that have been linked to H5N1 cases, not just of contaminated raw milk, but also there's been concern about raw meat and pet food products. And if people are exposed to the virus through their pets, it may be a different kind of exposure than what has been seen previously. So some of this is projection and possibly speculation, but I think that the scientists are really looking at this and trying to analyze the situation much like they did with other types of pandemics. And in individuals who are immunocompromised, this could mean either different kinds of mutations in the virus or a different clinical manifestation of the disease. So we'll switch gears now and say a little bit about influenza A, as the standard influenza as we call it. And this is a picture from the pandemic of 1918. And we know that it essentially was extremely severe. It was before we actually had antibiotics. And we know now, of course, that many of the people who died as a result of that pandemic likely died because of secondary bacterial infection and not from the flu itself. However, we know that a significant amount of morbidity and mortality is related to primary viral infection. And we know that certain individuals, particularly those who are pregnant, are at a higher than normal risk for developing severe respiratory complications. And so we should continue to urge our patients to get the flu vaccine. And although we're late in the season now, in the month of March, even though that's the case, virus is still circulating, and we should still urge patients to take the vaccine because they may not, even though they may not have a chance to get to a high antibody level, even having some protection is better than none. So as far as the weekly influenza surveillance report, these are some key updates from week 5 of the epidemic of the flu, which was ending on the 1st of February. Seasonal influenza activity remained elevated and continued to increase across the United States. It was the highest level of activity in over 15 years, and so this has been a very bad year for the flu. Outpatient respiratory illness was increasing and remained above baseline nationally for the 10th consecutive week, and all 10 Health and Human Services regions were above their region-specific baselines. As of that date, human-to-human transmission of the H5 had not been documented, as we said, but for standard influenza, there were 10 pediatric deaths associated with seasonal influenza reported during that week of the reports. And for the entire season, there were a total of 57 pediatric deaths. And this is sort of a sentinel kind of a occurrence, pediatric deaths. And we know that we can prevent most of these deaths if these children are vaccinated. And we have to try our best to educate the parents and let them know how important it is for the young children to be vaccinated. The CDC estimates that there have been at least 24 million illnesses, or at least were 24 million illnesses, 310,000 hospitalizations, and 13,000 deaths from the flu so far this season. We actually lost a dear friend of ours to the flu just 1 week ago. CDC recommends that everyone aged 6 months and older get an annual flu vaccine. And this is data from week 5 in terms of influenza. About 96% of the isolates were influenza A, about 3.9% were influenza B, and these are some of the cumulative figures over here, and this is from just the month of February, the month that just ended. And fortunately, oseltamivir for treatment and post-exposure prophylaxis is effective, and it's also effective in treating and preventing, we believe, the novel influenza A strains that we were talking about earlier. Ideally, as we mentioned earlier, it should be administered within 48 hours. And you can look up the published emergency use guidelines specifically related to the novel strains of influenza, because what they do is they actually will list some things that go above and beyond the package insert for oseltamivir or Tamiflu. And I think it's important for those who encounter patients who may have either been in contact or exposed to the novel virus that we know about that. As far as interim estimates, as far as 2024 to 2025 seasonal influenza vaccine effectiveness, there have been 4 vaccine effectiveness networks in the United States, and they've been monitoring things from October of 2024 to February, just this past month. And the CDC routinely monitors influenza vaccine effectiveness. The annual influenza vaccine is recommended, as we said, for everyone over 6 months of age. As far as the interim data that were derived from these networks, among children and adolescents, the vaccine effectiveness ranged from 32% to 59% and 60% in outpatient settings in these 3 networks. Now, this may seem low, but you're talking about people that are coming into clinics, and mild illness is not as well prevented as hospitalizations. And as far as against influenza associated hospitalization, the effectiveness was between 63% and 78% for children and adolescents. Among adults, the vaccine effectiveness was 36 to 54% in the outpatient settings in 2 of the networks, and 41% to 55% against influenza-associated hospitalizations. There's a lot of discussion going on right now about the effectiveness of the currently available influenza vaccines, and it's felt by some in the scientific community, the basic scientists, that we may not have as good a match this year as we had in some of the previous years. But the effectiveness as it stands still supports the use of the vaccination in everyone 6 months of age and older. So some summary points here as far as influenza A. It remains a major cause of hospitalization and death, and vaccines are effective in the prevention of hospitalization and death. The vaccines are indicated for all individuals 6 months of age and older, and treatment with oseltamivir, Tamiflu, is indicated and effective if administered early, ideally within 48 hours. We'll now switch over to measles. This is a photograph that's been around for a long time, showing a child with a generalized rash of measles or rubeola. We know that in African Americans, it is maybe and probably is more challenging to diagnose this based on the rash. And so this is an African American individual with the rash of measles. This patient actually had measles confirmed, and it actually started over the forehead, around the eyes, and then spread out to other parts of the body. So we do have to be particularly astute at picking this up in individuals. This is what happens as this child was convalescing. This is the xanthum sloughing of the skin in this child. This child actually was recovering, and I think recovered. And there's also, of course, the standard enanthem, the Koplik spots, as we call them. And you can see these little red areas there, and you often will see a white spot in the center. This is felt to be pathognomonic, or the sine qua non, so to speak, for diagnosing measles. I was mentioning earlier that during my fellowship, they told me that we would never see cases of measles. And now, of course, we're seeing measles all over again. This is another example of the Koplik spots and in the buccal mucosa of a person that was diagnosed with measles. And you can see here these spots with the white center. Measles, historically, was officially eliminated from the United States in the year 2000, meaning that there were no measles spreading within the country, and new cases were only found in someone who contracts measles abroad and then returned to the United States with the infection. Achieving measles elimination status in the United States was a historic public health achievement, and everyone was extremely happy when that occurred. And that was in the year 2000. So you're talking about 25 years ago. We should have had this, should have stayed, it should have stayed this way. It's very, very easy to prevent measles in most cases. And I'm sure our pediatricians who are on the call will agree that the dosing of the measles vaccine has been effective and is safe. It's combined the MMR, and usually it has been stated that individuals need to have at least 2 doses of the vaccine to have adequate protection. And this is how things went as we went from the 1960s, before we actually had an effective measles vaccine, to the current period of time, going to 2023. And of course, now we started to see upticks in the cases. Now in 2025, things have changed dramatically. So as of February the 27th, 2025, a total of 164 measles cases have been reported from 9 different jurisdictions. And so in addition to the most well-known outbreak in the state of Texas and in New Mexico, all of these other states have had outbreaks of the measles. So you can see that there are quite a few states where there have been a number of cases of measles reported. And of course, the Texas Department of Health and the New Mexico Department of Health have been most involved with this recent large outbreak in the state of Texas and West Texas. There have been 3 outbreaks identified, defined as 3 or more related cases reported in 2025. 93% of the cases, 153 of these 164 have been outbreak associated. And for comparison, 16 outbreaks were reported during 2024, and 69% of the cases, 198 of 285, were outbreak associated. And to give you a breakdown of the 164 cases, 34% occurred in individuals under 5 years of age, 48% in individuals between the ages of 5 years and 19 years, and 18% of the cases, or 29, occurred in individuals who were 20 years of age and older, and the age was unknown in about 1%. 95% of the individuals were either unvaccinated or it was unknown, and 1 in 3%, they had received only 1 MMR dose, and there were only 2% had actually received 2 doses of the MMR vaccine. In terms of hospitalizations, in the Texas outbreak, about 20% of the cases have required hospitalization. And this is 29% of those 5 years of age and under, and 13% of those 5 to 19 years. So it is very important for us to keep in mind, and for us to make sure that people know that we're not talking about something that causes a rash and that goes away. And we're not talking about a situation that some of our older relatives would talk about and say, oh, well, we've got a case of measles, so let's get all the kids together so they can all get the measles out of the way. The measles is a serious, serious situation, especially for young children. We know that currently the rates of hospitalization, and most of the hospitalizations are due to pneumonia. It can be quite serious, and to date, there has been 1 confirmed death in a school-age child. The measles, mumps, and rubella vaccine is very safe and effective. When more than 95% of people in a community are vaccinated, most people are protected through the so-called herd immunity. Vaccine coverage among U.S. kindergartners has decreased from 95.2% during the years 2019 to 2020 to 92.7% during the 2023-2024 school year, leaving approximately 280,000 kindergartners at risk for developing disease during the school year. We know that measles is highly contagious, and we will see anywhere between 12 to 18 cases, new cases, which result from exposure to each case. So it's highly infectious. So it's a serious disease in children, and it can be complicated by pneumonia and rarely by encephalitis. And when encephalitis occurs, this can lead to permanent cognitive deficits in that child. And up to 40% of children in some of the outbreaks have required hospitalizations. And we know that when the rates of immunization drop below 92%, there is a risk for outbreaks. And measles is totally preventable. So at this point, I will stop and I'll see if there are questions or comments that people have. I know it's been kind of a rapid fire thing that we've gone through, but for those of us who have not seen measles very much in person, it's time for us to actually have a refresher because as a result of the behavior of many people in our country, we are now seeing measles again. And I hope that the information that we've shared about the bird flu has sort of put you up to date. And I certainly hope that all of you will serve as advocates for making sure that we are encouraging I guess you would say, the renewal or the reversal of some of the stops that have been placed on supporting research in the area of bird flu, monies that have been set aside for some of the corporations to actually develop the vaccines. I think we need that needs to be done. And so I think that all of us need to be aware of these facts. And I think that it's important for those of us in the field of medicine, especially those of us African Americans, because we are usually disproportionately impacted, for us to advocate wherever we can. I know in my own Infectious Disease Society of America, I've joined groups that have gone to Washington where we've actually visited with the Congress people and the senators, their staffs, in an effort to try to get as much funding back as possible. So I'll stop here. It's always an honor and a privilege to be able to speak with this group, and I'll turn it back over to Dr. Nabreth Stevens. Thank you very much.
Thank you so much, Dr. Hewlett. That was a wonderful, wonderful lecture. And let me ask you one question just to start. Would you be clear, is there a danger in eating chicken or eating eggs to the consumer?
Well, as far as anything that's been pasteurized is going to be fine. So I think when it comes to eggs, I think there's a recommendation that we cook the eggs and we not eat them raw. I'm not certain about pasteurization of egg products, but if we have any milk products that are not pasteurized, then I think there is a problem. I think as far as the poultry is concerned, our hope and expectation would be that the poultry from sick herds or sick flocks is not going to make it to the grocery shelf. However, one would think that the cooking of the chicken would be effective in killing the virus. But certainly, if one were engaging in ingesting raw or uncooked meat, I would think that could be problematic. But I don't have any data to really back that up. But certainly, if we look at what's happened, what's been documented, where the cats are actually eating the dead birds and the cats are then getting infected, I would think that the same thing could happen to a human if they were to ingest raw or uncooked, undercooked poultry products. But I don't have data to back that up, Dr. Maxey.
Thank you. Dr. Barbara Navis-Stevens.
We had a question early on, which I thought was quite the question to ask. If you are an adult and you don't know whether or not you had measles as a child or your vaccination status uh, since the vaccine has been available. And there are certainly scenarios where you might have uh, received it through requirements at work or what have you. How do you know what should you do now in terms of getting measles vaccine? That was the question.
Okay. I think the CDC actually had, and I think they still have a guidance in terms of for people who were born before the measles vaccine was actually available, people born before the 60s, it's more like it's felt that more likely than not that they actually had measles during childhood. And so they the recommendations as far as the vaccines generally excluded those individuals. Now, with that said, they may start to change things now that we're having these outbreaks. I think for individuals that were born after the mid 1960s, and if they don't know their vaccination status, the question I guess would be, should they actually have a booster dose, or not a booster dose, but just get a dose of the vaccine? And I would think that would be a reasonable approach. Certainly if we can't document their status. In our health department, we have a lot of people who are coming in from other countries, and even adults who come in and they're essentially working towards permanent residency. If we don't have documentation, we just go ahead and offer them the MMR vaccine. That's the approach that we take if we don't have documentation. But that's just, our own health department. But the CDC actually does have some specific recommendations on how to handle that, but it may change.
Dr. Wonks?
Um, Thank you so much, Dr. Hewlett. I think for me, so much of what when you make the statement that the CDC recommendations may change, given the change in leadership at HHS, I think one of the things we're going to have to wrestle with here at Black Health Trust and in many of our clinical functionings is, where do we get the best advice, and do we take that advice that we have historically been able to take? So I don't want to get you into a challenging place, but can you talk about what your expectations are or what your concerns are about us being able to go to those reliable sources for information?
Yeah, I'm glad you asked the question, Dr. Walks, and it's not uncomfortable at all for me to at least give you my concerns. And I'm very, very concerned right now with the leadership that we now have at Health and Human Services. I have had the privilege of working on committees for the Infectious Disease Society of America, and we are actually holding some forums where people that know a lot more about vaccines and public health epidemiology than I are actually starting to come together and forming guidance and other types of things for the physician community, because I think the concern that everyone has had is that the CDC is not being supported as it should be. A lot of career scientists have been pushed out, and we have to come up with other ways to educate ourselves. And those of us, particularly in the African American community, I think that we have to do everything that we can to make sure that we're getting reliable information. So I'm working as best I can with the Infectious Disease Society of America. We have a group of African American infectious disease specialists known as the George Counts Interest Group. And all of us are really committed towards getting rid of and removing as much in the way of disparities as we can. And we have some very heavy hitters who are part of that group, people who have actually are part of leadership of the Infectious Disease Society of America. And maybe what I can do is share that list with Dr. Maxey and Dr. Nabreth Stevens, because I think that you have a lot of people who are really committed to providing education. and providing guidance, people who actually know the science. And I think that there should be an exchange, if you will, among those of us who are in the field. And I know that people in the George Counts group are more than happy to, provide their expertise. And there has been, and this occurred at the National Medical Association meeting this past summer, an effort to collaborate between the IDSA and George Counts and the NMA. So I think that this would be one thing that we can kind of do for ourselves. But that's just my own thought about it. But I'm very, very concerned about the lack of guidance and the lack of support that is occurring.
Thank you.
Thank you. Ms. Romero.
Hi, good afternoon, Dr.
Good
Hewlett.
afternoon.
How are you today?
Okay.
I really enjoyed your presentation. I have some couple observations and a question. I worked at a neighboring hospital from you in upstate New York, actually, so I really appreciate your comments. But as far as these infectious diseases, influenza and the bird flu, and also the measles, the implications for hospital workers are, increased amounts of training that we have to go through for PPE, training our staff, the burdens put on an already overstressed staff to now have to also give proper care to these isolation patients, educating the community. But my question about vaccines as a healthcare worker, I'm required to get a flu vaccine at the beginning of the season, or I have to sign a waiver and wear a mask for the entire rest of the season. But usually it's by October 1st that I have to get the flu shot.
Right.
But we often see the bulk of these flu patients come in later in the season, even January, February. What is the effectiveness, the length of effectiveness of these vaccines? Should I be getting another vaccine or a booster in January or February to get me through the rest of the season?
That's an excellent question. And all of us are generally told that we should get these flu shots from the month of September through the month of October. And in fact, I think that's based on the fact that most of the outbreaks occur before the month of March. Obviously, the effectiveness and the immunogenicity, as we call it, of the vaccine is going to fall off over time. I don't think that there's any data out there to support getting a booster. I am very troubled, though, because as you probably heard, the ACIP was scheduled to meet about 1 week ago, and that's the Advisory Committee on Immunization Practices. And one of the things that they were going to be discussing was the effectiveness and the safety and tolerability of the influenza vaccines. And so the scientific discussion that was supposed to be held, which is essentially a public forum, and anybody can actually listen to that discussion that the scientists hold. And these are academic people and public health people from all over the United States who hold this discussion. We didn't have that. So I really don't know what they were planning to say to address the very question that you've raised, because there were questions with regard to the effectiveness, and there may very well be a time when we would actually recommend a second dose. But as of this time, we don't actually have that data. I think it certainly is a good thing that we are recommending the influenza vaccine for our healthcare professionals, and not only for their health, but certainly for the health of all of the people that we care for. And also now, because we are so short-staffed, to be able to maintain a workforce, it's very important. So, but I hope that, I don't know if that completely answers your question, Dr. Romero.
Nurse Romero, but
Nurse
thank you.
Romero, thank you. I see Dr. Sherrod had her hand up, Dr. Nabra Stevens.
Dr. Sharon?
Oh, good afternoon. Excellent presentation, Dr. Hewlett. It's always
Thank
good to see you.
thank you. It's great to see you or hear you.
Yeah, I can't show up today on, but I'm so happy to have you here. I have two questions, and one is concerning the drop in immunization for measles. And are they looking at more people from outside the country? Did they break down that data in those who had less immunizations? That's the first question. And then the second one is I had some information on the measles booster, and there are two definite categories where you don't need it. That is, and I think you mentioned it's born before 1957 and vaccinated after 1989. And then there's a category where you definitely need it if you got the vaccine between 1963 and 1967 because that vaccine was deemed ineffective.
Hmm.
And then the maybes are 57 to 62 and 68 to 1989. I know that's a lot, but that there's a table, and I think this came from blackdoctors.com.
Okay.
Just
Okay.
because we don't really know exactly what to do. And I'm concerned about also the data disappearing from the CDC. I served on the ACIP for about 4 years.
Yes.
And so it's really kind of concerning right now as to what we're going to do if we have a pandemic, or you know what I'm saying? It's very disturbing. But I thank you for all the information that you shared, and great presentation. And there's always the discussion about whether the flu, how effective the flu vaccine is. The person I trained under, Dr. Cherry, is one of the major players in that discussion.
Mhm.
And most of the time they're saying that it's only about 40 to 50% effective,
Mhm.
but still recommending it. You know what I mean?
Mhm.
Thank
Is
you,
there
Dr.
Well,
anything
Dr.
though that you can do to prevent the bird's flu? That's
Dr. Sherrod, thank you so much for providing that missing information. And I'm sure that it will be helpful to share that with everyone. To answer your first question, as far as the people who are developing the measles, no, they are not just people coming from outside of the country. We have large groups of people who are, for whatever reason, getting waivers. They are people who are residents of various areas. Sometimes they're religious groups. The Mennonites, I think, is one of the groups that don't believe in vaccines, and they are involved with home schooling. And so they haven't been vaccinating their children. And then you have a number of people, and this was reported from, I think, from the state of California as well as from other places, affluent communities in where
mm,
they didn't want to vaccinate their children for whatever reason. And you saw outbreaks of pertussis because they failed to do that. So these are not people that are coming from outside of the country. These are people that were already here. In the past, it had been people who were coming in from other places where you had one case or two cases, but these are people that are already here. And what happens is you may have a person that comes in who has the measles from an outside place, and then everybody else who was unvaccinated is essentially part of the outbreak. That's my understanding of it. And in the New York area, we actually had outbreaks among our Hasidic Jewish population in Brooklyn. So that's my understanding.
Dr. Hewlett,
no,
so thank you so much. We're at well past the top of the hour. Would
Okay.
you care to give closing comments before our moderators give theirs?
Well, just thank you for having me. And I think we're in a crisis situation. So one of the things I would urge you to do, Dr. Maxey, Dr. Nabra Stevens, I'll share the list of infectious disease colleagues with you because I think that we want to make sure that whatever we know that you know when it comes to infectious diseases and pandemic preparedness and whatever we can do, and it's always an honor to be asked to come to share the information. And I certainly will look forward to trying to participate in some of your other meetings because I'm still an internist and so I'm still interested in hypertension and heart disease and diabetes. So thank you.
Thank you so much. I appreciate uh, final and closing comments, Ms. Romero.
I would just like to thank Dr. Hewlett again for such an amazing presentation. It's very timely. Unfortunately, it's timely, but it's great to have this information given to us in such a clear, precise manner.
Very welcome. And I'll share the slides can certainly be shared. I'll share the updated version because I added a bit on that New England Journal article.
So, Dr. Wilkes, we started a program giving honor to one of your previous colleagues. In your conclusion, would you just mention him?
Thank you, Dr. Maxey. Dr. Hewlett, thank you so much once again for coming to Black Health Trust and really raising the level of scholarship as you always do. So really, really appreciate you. We did mention, I smile when I think about Dr. Poussaint because I remember how closely Dr. Poussaint worked with some of the images on television, and in particular with the made up Dr. Heathcliff Huxtable and that entire opportunity for us to look at African Americans on television in a very positive way. So I do remember Dr. Poussaint quite fondly. But I also want to make another closing comment that leads back to the question I asked Dr. Hewlett. I don't know if many of us remember that Dr. Francis Collins, who ran the National Institutes of Health for some time, retired over the last few days. And he was a presenter with us on Black Health Trust once upon a time. And the level of several things. One was, and I'm taking just a minute, Dr. Maxey, if you can forgive me. Dr. Francis Collins was not an African American person, but thought it not a bad thing to spend his time on Black Health Trust, talking about the health of all of us, because community health is a very important thing. And my concern is not that he's retiring. He fought the good fight and ran the good race and all of that. My concern is that the person that's taking over his position has publicly said disparaging things about Dr. Collins. And so as we look at transitions and changes in very important functions in our larger healthcare community, I think we have to be aware of those. I want to request that Dr. Hewlett actually continue to update us as the organizations with whom he is working actually create information that we need to have so that we can have reliable sources of information. I don't know what's going to happen at NIH, but I do know that it's a concern when someone who has taken time to work with us, who we feel has done good work, is being replaced by someone who is saying bad things about that person. And it feels really uncomfortable for the future. So this is a time for us to pay attention, a time for us to work together, and a time for us to celebrate folks like Dr. Poussaint, who we no longer have access to, and Dr. Collins, who we hopefully will continue to have access to, whichever role he continues, whatever role he goes into. Just a good guy that spent time working with us.
Yeah.
Oh, and Dr. Lisa Kervin Dawes put her hand up, Dr. Maxey.
Hey, Dr. Dawes?
Yeah, I actually knew Dr. Alvin Toussaint. He was at Harvard when I was there. He was very involved with the minority students and actually very helpful. I think he'll be sorely missed. We have sort of kept in touch off and on over the years. I just want to say that it seems like a lot of our great people are disappearing one way or another. Actually.
Thank you so much, Dr. Lisa Kervin Dawes. Dr. Barbara Neighbor-Stevens.
Well, I too want to express my gratitude to Dr. Hewlett and invite him to continue to keep us enlightened on the things we need to know. And I want to remind our audience today to remind your circles that our shows are archived on YouTube. And so shows such as this, at a time such as this, is really important that people know where they can get reliable information. So if you could spread the word in your networks that these programs are available so that they can get the information that they need. It would be very helpful, I think.
And thank you so much to Ms. Romero, Dr. Walks, and Dr. Barbara Neighbor-Stevens. I'm going to say I listened to 2 sermons this morning on YouTube, and both of them involved the chapter on Revelations. And they both talked about end times, and they both talked about the Antichrist. And they both assured that without any red or blue connotation, that the current leader of the so-called free world is too dumb to be the Antichrist. It's going to be much bigger than that. But we need to keep our hope up. We need to keep our faith up, because as Bishop Noel Jones has assured us, that faith is the bridge by which Jesus passes mercy across all of us in our survival. Thank you, everybody. See you next week. And thanks for joining us this afternoon. Thank you very much, Simon, for helping.
Good day, everyone.
Thank you, Dr. Hewlett.
Bye.